the point being, mom's a linchpin, right? And if she's not okay, then no one's okay.
Dr. Carly Snyder from your studios in New York City. How are you doing, my friend?
I'm good. Thank you so much for having me. I'm excited.
I'm excited to chat with you. Let's start. This is an interesting specialty. And I remembered when I had you on Specialty Stories, I was really intrigued by the psychiatry that you practice, this weird thing that nobody exposed me to during medical school. Me neither. Reproductive and perinatal psychiatry. I told my in-laws that I was speaking to you yesterday, and they were like, what the heck is that? Right? My in-laws, who've been on this planet for 70 plus years, have no clue what this is, and they've had multiple babies. Mm-hmm. Talk to me about reproductive and perinatal psychiatry. What is it?
So it is a really small subset of psychiatry. We're like a close-knit group. I work with women struggling with emotional symptoms throughout their reproductive years. So I see women really, I have some patients who have severe PMS called PMDD, but, I have some women who are coming to see me because they're thinking about getting pregnant and they want to know what to do. Maybe they have a history of something in the past, mood-wise. A lot of my patients are already pregnant. A lot of them are postpartum. And what I do is I help them kind of manage and deal with mood symptoms in really, I think, sensitive times in one's life, right? Like if there's any ever thing that you don't want to screw up, it's having a kid. But the flip side is women who have a history of any mood disorder or what have you, they're scared because there are all these meds and there's all this misinformation around. So my job is to help women remain ideally stable throughout the process of trying to get pregnant, being pregnant, postpartum, and then helping them with motherhood, which can be stressful unto itself.
Why a subspecialty in psychiatry versus general psychiatry taking care of the same patients?
So it's a good question. Two things. Number one, I don't think I would see the same. I'd see the same patients on occasion, but I have a, like mass on mass. And I really love my patient population. I did not enjoy psychiatry as a regular psychiatry. It's, inpatient psychiatry was really no fun for me. But I love that I can treat women and they get better and they do well. And we have really recognizable and effective modes of therapy. I couldn't see myself kind of doing the general psych thing on a regular basis. Like this is so subspecialized. And also it's cool because there's a lot of overlap with medicine, endocrine, rheum, we obviously OBGYN. I work with so many different physicians, reproductive endocrinology. Like I wouldn't have that opportunity if I were doing general psychiatry.
Yeah, very interesting. I love the fact that you said you didn't enjoy your general psych time. Mm-hmm. I think a lot of people going through this process, and the majority of people here watching are pre-med students, and so they're years away from this still. But I think I wanted to talk about it because of what you said. A lot of people who go through this journey, who hit those periods of their residency or medical school where they are completely devastated with what's going on in terms of like just not enjoying it. And they have this crisis of faith that says, I shouldn't be here. How did you get through that, knowing that there was something on the other end for you?
So great question. So the first answer is I didn't know I would initially. So I got into medical school. I got into NYU with like 3 other people in December. Like I got an email saying, congratulations, Happy New Year. And like I hadn't anticipated, right? But like everything was going towards med school. There was no way about it. And I got to medical school and to say I floundered, maybe the understatement of all time. Like I didn't like it. Like I didn't. And my dad's a physician, and I called him many times and said to him, you know what, I'm done. I could be a party planner. And he was like, yeah, no. Like, I mean, he said, you have to do something, like, you don't have to be a doctor though if you don't want to be. And giving me that permission in my own way pushed me to continue and just to say this sucks and to move on and assume that it'll get better. And then I really loved surgery when I was in med school. Like I was totally into it. It was my plan. It was my goal. Then, you know, life interceded between, I had a baby. I also have this thing, this autoimmune thing. So my fingers get a little numb on occasion. That really doesn't work with surgical practice.
Not so much.
So yeah. So I had to change course really quickly. And that was hard. I, for a multitude of reasons at the time, didn't want to do a general medicine residency. So I went on psych. It was like, okay, my dad's a psychiatrist. Cool. I'll do that too. And then I got there and I was like, holy crap, this is not what I signed up for. There were, I went to Beth Israel there's a really sick population. I mean, just the vast majority of patients that we saw were incredibly ill, didn't get better, were like frequent flyers. You know them. I mean, on the one hand, we got to know patients, which was nice, but we knew them because they were so ill and so chronically ill. And I had a hard time with that because I didn't feel like I was doing anything.
Yeah.
And then I got really lucky through, several convoluted steps. And one of my senior residents' wives was a reproductive psychiatrist, and I'd never heard of that. I met with her and I was like, you're the coolest person ever. And I got, fast forward, did an elective at Cornell where I'm still in attending now. And I was like, oh, okay, this is why I'm meant to be doing this. Like, I get it now. So I would just say, find what you like. Like there's so many parts of medicine. There's so many niche things. And, just because your residency isn't what you anticipate it being, doesn't mean anything about your future.
Yeah. Let's talk a little bit of the business side of things. A good question that came in is how are patients referred to you? Now, a lot of students don't realize medicine is a business and having a private practice is a business, and you have to get your name out there and market yourself. Because it's such a small niche, how do you make a name for yourself? How do you let the OBGYNs and the family practice docs and the primary care docs know that you're out there for their patients?
So I got really, I guess it was luck. Whatever it was, right out of residency, I was the director of women's health at Beth Israel, which is a really fancy title, which meant I was just embedded in OBGYN. But because of that, I had a network there, and I had a network at Cornell already. So that kind of started things. I have a amazing group of colleagues and friends who, we all go out to dinner together. We're all friends, but we're also work together and we refer patients back and forth. So that is a huge source for me. And a bunch of them, we all went to med school together as it happens. Some of us, some age is different. But another thing, with the OBs, it really is a function of like, if you get a patient somehow, you pick up the phone and you call and you speak to them, and then they have a connection. And same thing with pediatricians. And, you can say like, oh, who's your peds? Do you want me to talk to them? And then you call and then they know who you are. So next time they're like, oh, wait, I remember this person. I also do a fair amount, or I'm on the board, or I was on the board, and now I'm on the advisory committee for Postpartum Support International. And through that, I connected with a lot of people. And a lot of my patients now, they come from other psychiatrists, they come from therapists, OBs, internists, whatever. They also come from each other. So there'll be a dinner party, or pre-COVID dinner party Friday night, and then I'd have like 4 new patients on Monday.
That's fun.
And it really is, if one person trusts you and likes you, it really helps. And, there are random things that I had nothing to do with. Like there's some PMDD website and someone put me on it and I get a bunch of referrals there. No idea how, but that's what happened. Similarly, if patients like you, when someone on Facebook in a mommy's group or whatever group says, I need a psychiatrist, they're like, oh, you should see mine. And then it goes from there.
Yeah. Word of mouth is so powerful.
So powerful.
A good question that I just saw scroll by. How often, if at all, do you take care of spouses and bring spouses in to talk about the stress of them having a child as well?
So it's an awesome question. There are two parts to that. So up to 50% of spouses whose partners are suffering from a postpartum or a peripartum illness, they themselves will have depression or anxiety. And often they will undervalue their own symptomatology in the interest of supporting their partner. Yep. But both people need to be okay in order for the family unit to be okay. I don't treat the partners because it's a conflict of interest, and I am my patient's doctor, right? And that being said, I have a lot of interaction when needed with partners. I am a very big believer in autonomy. So if my patient wants her partner to come in, I'm like all for it. If not, I do not mandate it. There are definitely people in my field who do make partners come in and kind of understand, but I don't really think, my feeling is that my patient can make a decision on her own for herself. And if she wants to get her partner involved, that's great. But I definitely have a, referral network of other psychiatrists who do see partners, and I'll refer, I'll ask how he or she's doing and then refer as needed.
Yeah. Awesome. All right. I want to jump into the slides because you spent a lot of time and they're awesome. So I want to get the students to see those. So if you want to launch that again, you can.
Or I will say some of them we'll skip over real fast because we kind of talked about it. But yeah, here we go. Okay, so there we are. That's me. That's what I do. Okay, so I love this little clip, right? So it says they say she accidentally drank a caffeinated beverage, and there's this woman with a 3-headed baby, and I try to always remember this 3-headed baby because this is what people fear, right? This is what we all, as moms, want to avoid, is something wrong happening. And no one likes being talked about, and people talk too much. People talk amongst each other, people criticize, and it's so important to remember that outside factor when you're treating, because it is important. People sit it, and their mothers, sisters, second cousin twice removed said they shouldn't be on that medicine. So now they're going to stop it because they're worried about a 3-headed baby. And in fact, that's not true. So we kind of talked about this already. What is perinatal reproductive psychiatry? We went through this, but the big thing that I didn't say before was, a lot of what I do also is about adjusting to motherhood and adjusting to even the idea of motherhood. Because women deserve and need to remember they were people before they were moms, and they need to still find that inner self and figure out their identity. So that's kind of a cool part of what I do as well. Why pick what I do? Well, I'm biased, obviously. I think my patient population is awesome. Also, you are helping women in the most direct and profound way. Motherhood is something that most of us who want to be moms think about with the most positive of imagery. And then when it doesn't go that way, it can be incredibly painful and scary. So you're really helping someone get to a point where they can enjoy what they had anticipated enjoying. Also, treatment works, right? As I said before, in some parts of psychiatry, you feel like you're on a hamster wheel. In my area, we don't. Treatment really is effective, and we have a lot of options. The other thing
there's got to be a big downstream effect that you are having on just the world, because these moms, these families are hopefully whole as they can be because of this treatment that these patients are receiving. And so the children are being raised in more stable environments, and they go on to have children of their own. And so there's just this huge domino effect, the butterfly effect that you're having on the world.
Well, I love that. That's really sweet. I will say that there's a very clear family impact, meaning, we know based on data that if a mother is sick from the STAR-D trials, right? If a mom is sick and she's remains untreated, her child, elementary school age, whatever, has a much higher percentage chance of being diagnosed with something, depression, anxiety, fill in the blank, within the next year. If you treat mom, the likelihood of that child having any kind of diagnosis in the next year goes down astronomically. The point being, mom's a linchpin, right? And if she's not okay, then no one's okay. The other thing that, as I said before, I really get to engage with a lot of different parts of medicine, a lot of different specialties. There are some cases that are super, bread and butter, easy, but there are some really complex cases that we get to see. And they're puzzles that are great to figure out. There's a lot of really great research going on. The only thing I'll say is one negative is you really do have to contend with a lot of misinformation and a lot of lack of education, for lack of a right. Like, I didn't hear about what I do in medical school.
Yeah.
And I definitely had, attendings in residency say, stop your medicine, tell women stop your medicine, like, without even a hesitation.
Yep.
Which is wrong, depending on most of the time. So you kind of have to contend with that. And like pharmacists who will say to patients, oh, you're pregnant, you must stop that Zoloft. And it's like, no, they don't. Like, no. And then they call you and they're freaking out. And it's the whole thing. So that's the other part.
Or they read on Facebook.
Oh, right. A Facebook friend said their baby will have 3 heads. So that's annoying.
Interesting question that just came by, just with the kind of the state of the world that we're in now, with more and more transitions for trans men who still menstruate, who technically, if they keep their uterus, can still have a child. Are there any differences in terms of treatment for those patients?
It's a great question. I don't yet have experience in that scenario, but I can't imagine why there would be any difference beyond, look, if we're doing therapy, the therapy is where the person is at, right? So they drive that ship, right? So whatever's going on with them is what we discuss. And from a pharmacologic standpoint, there's no reason to assume there would be any difference. If someone's carrying a child, they're carrying a child.
Interesting. Okay.
So before I jump into a bunch of cases, I just want to give a little background in what I do so that people understand kind of the general rules and such. So one thing that's really important to remember is perinatal mental illness. So that's like during and after pregnancy. It's really, really dangerous if untreated. There's more and more data suggesting that the risk of treatment for all except Depakote, which should never ever be given to women of reproductive age because it's like the devil for all intents and purposes. But most medicines, in the face of moderate to severe illness, the risk of illness is far greater than that of exposure to medicine. So risk benefit really goes towards treatment. Suicide is one of the leading causes of death in the first year postpartum. And so the severity of things can't be underscored. There are a whole bunch of perinatal mood and anxiety disorders. There's a little asterisk next to baby blues and postpartum psychosis because those are the only 2 that can happen purely postpartum. The other ones can be seen in pregnancy and postpartum. This is just a quick reminder. There used to be this thought that like you got pregnant and then butterflies started floating around your head and you like ran in green pastures all the time and you would never be depressed or anxious because you're pregnant. And that's just not true. There's no inherent increased risk of illness, but the risk definitely doesn't go down. Just quick, kind of push for treatment. If you look at these numbers, they're pretty disconcerting to say the least. Essentially, we're saying that less than 5% and less than 4% of women ultimately achieve remission from these, various PMADs, which is just says there's we have a far way to go before women really get adequate care. And they're not right now getting adequate care. Why aren't women treated more? There's still a lot of shame. There's guilt. There's stigma, right? Why am I feeling this way? I must be a bad mother. I'm not going to tell anyone, which is completely wrong. No one's a bad mom for having a PMAD. It's, I always liken it to diabetes or anything else, right? Gestational diabetes, hypertension, all these things happen. And for, plus minus 1 in 5 to 1 in 7 women, so will a PMAD. And that's not an indication of how someone is as a mother. It's just biology. There are definitely not enough trained providers. There's also no specific clear professional guidelines. Obviously, we all work with a similar rubric, but the APA, ACOG, they haven't come out with this is how to do it. They have their own definitions, which interestingly differ in terms of what defines postpartum depression, but that's a different issue. The point is we don't have any, hard and fast rules, and the other big thing is prescribers' fears and antiquated understanding.
It seems like the common trend that I see, unfortunately, with specialties that are more focused on women is that the women are underdiagnosed, undertreated. There's just this common thread throughout of a lot of the stigma and shame and lack of understanding, or more of the quote unquote hysteria diagnosis or stuff like that.
Yeah.
How do we overcome that as a medical field for all these 1,200 future physicians watching this, listening to this? How do we overcome that?
We think about each patient, A, as a unique individual, and B, what if this person was your best friend or your sister or your mom or your whomever, right? You have to respect everyone and respect that everyone's experience is different from yours. So I think women get labeled as, for hysteric, great example, right? Or, they're just being needy and, everyone took care of them in pregnancy and now no one is, so that's their problem. It's not true. Yeah. Right? And you think about it if you knew this person if this was someone you loved, would you be minimizing what they're experiencing? The likelihood is no. And if the answer is yes, then you kind of have to think for yourself what's going on. But there's no reason to assume that women are, doing anything beyond reporting symptoms as they experience them. And if anything, I think often women minimize symptoms because we are the caregivers. We tend to worry about others before ourselves. So people really are quick to minimize so once they're actually asking for help, you have to really, applaud that and treat them, not try and figure out why what they're saying isn't legit. If that, yeah. So it's why treat? Well, mostly the big answer is because women deserve to be treated. First and foremost, these are kind of the specifics, but overall, the end of the day, if a woman is treated, she will have a healthier pregnancy. And that's kind of the take home. If a woman is sick, she cannot care for herself the way she needs to. And there are lots of medical complications as a result, emotional complications as a result, lots of reasons to treat. Now, in addition, there's actually risk to that future baby. So there are these at delivery, for example, you have lower APGAR scores, et cetera. Basically, the way to think about it is mom's body, right, is literally one with this future child. If mom is living in a state of panic or anxiety or depression or whatever, that baby's living in this world of, that isn't calm, to say the least, right? And there are negative complications from that, and there are negative repercussions. And you kind of want to think about it like the milieu, and you want it to be as good and baseline as possible. Does that mean every day is going to be great? No, absolutely not. But overarching, yes. And we even have data now looking at epigenetic changes that occur in the placenta that allow cortisol, for example, to cross much earlier in the setting of untreated illness. So these babies are literally, they are being exposed to this wave of cortisol unnecessarily. And there's something called quickening. They have to they develop neurologically faster. There's all this stuff, but the long and the short of it is we need to treat. It behooves everybody. And this is just kind of quick aside that there's, people get worried about medication causing the various developmental stuff, but in fact, it's untreated illness that is most likely to cause developmental delays, various diagnoses. And this is all not even taking into account the impact of postpartum illness on a child's long-term development, which is huge. And if anyone's read about attachment theory and what have you, it's incredibly important. So this is just solely based on exposure in utero. And then postpartum, there's a whole host of additional things. Really quick clinical considerations when we talk about medication. First and foremost, don't prescribe Depakote to a woman of reproductive age, please, because it's just not safe in pregnancy at all. But beyond that, my little golden rules, keep it simple. If someone's doing well, don't change it, right? If they're doing great on Lexapro, keep them on Lexapro, don't question it. Monotherapy, being one medicine, is better than two. But in practice, women who are really sick sometimes need 2 or 3, and that's okay. Our goal, again, is to keep them stable. And you want to dose the lowest effective dose, not just the lowest dose. And, remember physiology when you're treating a pregnant woman, their blood volume almost doubles, their metabolism changes. And if you think about it dilutionally, they might likely need more medication over time. They don't all, but they likely will. The other things to remember, document everything. And this is, I think, an important point in any practice.
Yeah.
You have to document, up the wazoo, because it covers your ass. It covers your patient as well. And while it's kind of a pain, it really, really makes a difference. And you'll thank yourself later if you do. And therapy, I think if we were all in therapy, the world would be a better place. So we should definitely recommend for our patients that they're in therapy. So then here we have case studies, which is probably the more interesting component to things, right? So here we have our mom. She's married. She's employed. She's like, I think I want to have a baby in the future. Okay. She's been on Prozac, fluoxetine for ever, for years and years and years. And she comes to see you. What do you do? Her life is so different now than when she started it. And she's saying she has time. So try and lower the dose. Let's see how it goes. Now, it's possible you lower it and she becomes really depressed or anxious. And you're like, okay, great test. Let's go back up. But a lot of times you lower it and they're like, oh, I feel the exact same. So then you stop it. So that's that one. It's pretty easy. Now, Constance, she has more moderate. She has severe illness. She's had a suicide attempt. She's been on Lexapro for, years and years. In the past, she has tried to stop medication and it doesn't work. She gets sick. And there's also something called PME, which is premenstrual exacerbation, meaning she gets worse mood-wise before she gets her period. So now she's like, what do I do? So she comes to you, she says, I started lowering my medication on my own because I figured that was the right thing to do. And now I am, a mess. So then I upped it again and I'm good to go. What do? You keep her on what's working. You know that lowering it's going to be a problem. And interestingly, what happens is if someone stops their medication, and they get sick. Now you have to like hit them harder, right? You now need to deal with the active illness versus something which has been controlled well, and you can stay on the same dose. So it behooves you to leave well enough alone when you have a history of moderate to severe illness. And this is really important. Everyone's scared about exposure to everything in pregnancy. That's normal. And as physicians, we have to respect that and explain and give data and allow the patient to make their own choice. Like, I don't make a choice for anyone. I'm there to support them. I don't have a heavy hand. If they don't want to be on meds, that's fine. We'll figure it out. But that could, be difficult or not. Like, it's their choice. It's not mine. I just give the information. They go from there. So then let
me ask you a question before we jump into the next case. Yeah. For you and your specific practice, how much are you doing therapy with patients versus managing medications? That's always a big question that students have between therapy, the psychology versus psychiatry. So
I have, at any one time, usually 4 or 5 patients who I see every week. Sometimes it's 7, sometimes it's 3, whatever. The rest of my patients I'll see anywhere from every 2 weeks to every 3 months, depending on their situation. Because of mostly financially driven patients, sometimes, will see me for 15-minute med management visits, but most of my patients see me for at least 30 to 45 minutes if they haven't seen me in a while, or if they have even, they have to fill me in on everything that's happened since we last saw each other. So there's a lot of supportive psychotherapy that happens, just sort of the idea of like, this is going on in my pregnancy. Is this okay? Kind of helping them understand things. And then obviously the patients I see every week, they're different. Some of them are on meds, some of them aren't. But, it's variable a little bit.
Yeah. Okay.
Our next one, so she's already pregnant. She's got a high stress job. She wanted this pregnancy really badly. She did IVF 4 times. She had been on paroxetine or Paxil until she stopped the medication because her fertility doctor told her to. And she's been something of a mess ever since. She can't really work so well. She has vague suicidality. She doesn't have a plan, but she's definitely thinking about like, life is not what she wants right now. What do you do? And the thing that's interesting about this case specifically is the use of paroxetine. So Paxil has this really bad name. People think you shouldn't use it in pregnancy, and that's not true. It's that same idea. If it's working, don't change it. Now, I'm not going to start someone on Paxil as my first, option. But if they're on it, and for this woman, I would resume it because we know it works. And if someone's on it, like beginning of pregnancy, a lot of times they'll end up with a second trimester echo. Fine. But the point is, this woman needs medication and she needs Paxil because that's what's worked for her. And then, we have our unplanned but welcome pregnancy, right? She's 24 weeks. She sounds like she had a panic attack. She has lots of symptoms, like legit symptoms. She went to therapy. It really isn't working. What do? We treat her. And the thing to know in this one is, if you look at her symptomatology here, right? So her GTT, her glucose tolerance test, was off. Her blood pressure is high. These are all ramifications of untreated illness that have to be addressed and can, are things not to forget about. Also, I didn't put it in here, but always check the thyroid function. That's really important too. The thing also is, someone like this woman who's really sick, she may need an SSRI plus a short-term benzo. Okay. That's okay, right? Because SSRIs don't work right away. But she needs treatment because she's going to have a baby, and we need to safeguard her now and in the future going forwards.
How much of your time, or how often do you have to have heated's a strong word, but debates with other care providers, the OBGYNs, who are like, no, I don't want my patient on this medication. And you're like, no, they need to be on it.
Really infrequently. It happens. Mm-hmm. Pharmacists and I get in on it a lot. CVS does not like me because, yeah. But often physicians are, either already know and they're the ones who are like, oh, you should definitely be on meds. Or when they don't know, when you present them with legitimate data and evidence-based arguments, rather than saying, I really feel like this is important. But if you give them, research and you say, listen, look at this paper, look at this. They want the best for their patient also. So they come around. And if they don't, you say to your patient, listen, I tried. And again, it's the patient's choice how they want to proceed with things.
Yeah.
But I'm also in New York, which is probably, modifies things a little bit. There are, big parts of the country that don't have any physicians who know anything about this.
Yeah.
So if you're the one person who does, you may have to run uphill a little bit more, but just run harder and faster. This one's interesting. So this is one that will freak people out until they know what's going on, as in providers, providers. So she's having something called intrusive thoughts, right? Which are awful. And they're in the vein of OCD. So the women are aware that they're not reality-based, but they can't turn them off. And it's like a constant flow. And the thoughts can be anywhere from, like, what if I stab my belly? What if I, what have you? Or what if I put the baby in the microwave? Which seems crazy, but like, I've heard that one. I've heard it all.
Yeah. But it's safe, and correct me if I'm wrong, but it's safe to say that sometimes these thoughts are normal, right? We have weird brains and we think about it and they go away and we're like, that was silly.
Oh,
what's the difference between us having those thoughts and it being something that needs to be taken care of?
So the difference is whether we can compartmentalize it and turn it off. So I'm a very big believer that intrusive thoughts on some level have a purpose, right? We all have them once in a while, especially as parents. If we wouldn't have, like, we have toddlers in helmets an inch off the ground.
Yeah.
Why? Because in our head, we go through this, oh my God, what if, fill in the blank, right? So we stick a helmet on the kid and the kid's fine. The intrusive thought really in that scenario presents to allow us to think of the worst case scenario and then fix it and to do whatever we can to avoid it. Women who have, clinical illness, they cannot conceptualize it. They can't contextualize it or compartmentalize it, all these C's. So most importantly, they can't turn it off. So it's like a nonstop reel in their head of, like, I literally had patients who throw out the knives in their house because they cannot stop thinking about what they will do and visualizing blood. I mean, it's terrible. Yeah. So the difference is really how one handles the isolated thought, but then how often the thoughts come. And I have this theory, which is completely not scientific, but it's my own, that if you think about our primitive brains, like, 1,000 years ago, women walked around, had to think about, what's in that cave around the corner? And is there a mountain lion there? Am I going to take my baby to the cave with the mountain lion? No, but I have to think about it first. Like, I have to go through that, exercise. When we're exhausted, anxious, depressed, struggling, and sleep is a huge thing that we haven't talked about, but like sleep deprivation is so key in all this. Our brains go back to that mountain lion. The difference is now the mountain lion is like the microwave or whatever, right? There are things that we inherently were like, okay, what am I thinking about? But we're in such a primitive state, especially sleep-wise, because we're so exhausted that our brain goes into wonky places.
Yeah.
And it's so incredibly important that you tell patients that it's okay. If they are freaked out by the thought, I'm not. It's the women who are not freaked out by the thought, who sit there like blank face telling. Those women are in the spectrum of psychosis, and I am worried about them because that's an emergency. But the women who are sitting there crying, feeling like the worst person in the world because they're having these thoughts, they will never hurt their child. And they will respond. They need probably higher doses of meds and they need therapy, but they do well. And it's actually way more common than one thinks. The isolated thoughts are really common, but even the OCD, intrusive stuff. And these are some common ones if anyone's interested in them. Like, they are really, really distressing and awful. And if you imagine now having them all the time, it's like living in a nightmare. But this is just reinforces what I said before. Women with OCD, which is this intrusive thought stuff, they are horrified. They will not hurt their baby. Postpartum psychosis, which is a psychiatric and medical emergency, they do have the risk because they are completely out of touch with reality. They are not in the same realm as us. So they think the baby's possessed or demonic or whatever is not their baby. I mean, but the thoughts no longer freak them out. So they're ego-syntonic versus dystonic, right? So it's delusional. It's bad. And if you just look at these numbers, they're scary. There's, 4% risk of infanticide and 5% of suicide. So in that scenario, a woman needs to be in the ER and admitted. Like, don't pass go. Don't collect $200. This is just sort of a general rule. Medication, really helpful. Therapy, really helpful. Lifestyle, like sleep, imperative. I could prescribe up the wazoo. Someone could be in therapy all the time. If they're not sleeping, they're not going to get better. They need.
Which is like that's like God's little trick, right? I'm going to give you all of these things that come with sleep deprivation, and you have an infant, which causes sleep deprivation.
Right. And that's why, like, women who I see before they deliver, I'm a huge fan of making a plan with their partner, saying, like, this night you're going to do X feeding or bring me the baby but then you're going to take the baby and burp the baby, blah, 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 at this time. Then we're going to switch off and blah, blah, blah. Because if you wait until the baby arrives, mom is going to do everything.
Yeah.
And then she's going to become a shell of a person.
Yeah.
Right. And we are all, I always tell people, like, we used sleep deprivation as a form of torture in Guantanamo.
Yep.
It is torture. And if you don't sleep for long enough, you will start feeling like you're nuts. You just need sleep. So then quickly, I have a couple more new mom ones. This lady, she's 3 days. She has a new baby. She has no psych history. She's crying. She's like, I don't know why I'm crying, but I can't stop. I always tell my patients, like, when I had my first, we didn't know, what car seat to buy. We didn't know anything about anything. And we bought, like, the convertible car seat because financially it made more sense. But we didn't buy the infant car seat. That seemed silly. But obviously that's what we should have bought. And we got in the car with him, and he was this little guy in this huge car seat. And I was hysterical. And then we're driving. My husband's like, hey, he's fine. He's sleeping. And I was like, I know, but I can't stop crying. There's nothing wrong. I have baby blues. 90% of women have it. Your hormones are going from over 100 times their baseline, and they are taking a nosedive like no one's business. That's fine. Don't treat that. Let it be. If that lasts for more than 2 weeks or it's severe, that's a different issue. And that's where we go into depression. But just being tearful and kind of what we call labile transiently, that's just being a new mom, and that's okay. So here's another one. This is kind of the one that we all kind of fear. So woman sitting there, she's holding her baby. She is not responding to that baby at all. There's like a blank. She's present, but she's not present. And she tells you about her, maybe she does, but like her intrusive thoughts, and she's not upset at all. It's like deadpan. She's not sleeping. Happened, maybe a few days after delivery. Maybe she has a history of bipolar disorder or a psychotic illness. Maybe she doesn't. This could be a first episode. This is postpartum psychosis. This is when you say, can I hold your baby? I love holding babies. And then you pick up the phone, you call the partner and you call 911 and you have her brought to, because she is a danger to herself. And the only option really is to go to the ER. There are gray area cases where, you know, someone's family is super involved and the woman has some moments of sometimes they're lucid. So, you know, but those are the ones where I don't sleep at night until she clears up. All things being equal, she needs to be in the emergency room. She needs to be admitted for her safety and her baby's safety. And then you got this one. This is a woman who I see all the time. She's a few months postpartum. She's taken on everything. She's not sleeping much because she can't. She is so anxious. She's so tearful. She's like, she is miserable. But she's been miserable for a fair amount of time, and she's ignored her symptoms because she thought this is what motherhood was supposed to be. And it is not supposed to be like this. So this is the woman who you put her in on meds and in therapy, she clears up and she is like a new person. She is so much better. But before that, she is in hell. And there are all different reasons that this can happen. You know, biology is important, experiences. Breastfeeding can really be a difficult thing that can really trigger people. Having a traumatic delivery, also really difficult for some women. And it's super important to remember, it's about a woman's experience of delivery, not the medical side. So a woman could have what, as doctors, we think of as like the perfectly healthy delivery. Baby's fine, all is well. She experiences that as a trauma for whatever her reason. That is traumatic then. And we have to use her experience as the litmus for what's going on, not our, but your baby's fine and nothing happened. That's irrelevant. What matters is her experience, because she is, that's what is, you know, in part potentially impacting her current presentation. The other thing in this scenario is you need to get her help with the baby. So, you know, it's hard with COVID, but partners need to step up, or, you know, their mother or whatever, get someone quarantined for a little bit first. It doesn't matter. She cannot do this alone because she shouldn't have to, because it's so isolating. And if she doesn't sleep, she won't get better. Oh, I threw this in mostly because it's kind of interesting. I gave a lot of speeches for Zulresso until COVID happened and then stopped. It's a really, really revolutionary option for women with really severe illness who are not responding, or, you know, for various number of reasons. It works in 3 days. They are, you know, the vast majority of women do incredibly well. There's a huge price tag to it. There's different issues, but most interestingly, they are working on an oral formulation, which will be a huge game changer in my field once it comes out, because it will work quickly. And that's something we don't have right now. Beyond, yeah, it'll be awesome. And trials kind of got a little sidetracked by COVID, but on the way. Yeah, right. COVID sucks. Anyway, the other great thing is you get to see cute babies with what I do. And, you know, I love babies. So that's a plus, right? Like I got 3 new baby pictures today in my email from 3 of my patients who had babies over the weekend. Like, that's pretty fun. That's awesome. Yeah, you know, you really make a huge difference in someone's life. So there you go.
Here we go. Let's see if we can bring on 2 students for a question. If you want to raise your hand to speak, I'll let you in here. There's one here and one there. We'll get 2 in there. See how they do. Well, thank you again for coming on. And if you're watching this, Dr. Snyder was on Specialty Stories, the podcast that I do, very similar to eShadowing, but podcast form, session 94, which you can get at specialtystories.com/94. So you can go check those out. And there's some details too. All right. So we have Hannah here. Hannah, can you say hello?
Hello. Can you hear
Hi.
me?
Yep.
Hi. Okay. I have 3 questions. Is that okay?
Maybe we'll see how
They're
fast they
quick.
go. All right.
Okay. So my first question is, I know that like working a lot with, I know that like for surrogacy, like they say you can't be on antidepressants and you can't be in need of antidepressants.
You mean as the surrogate herself? There's a huge amount that goes into being a gestational carrier or like it's women who are couples who are using someone, as a carrier. They get the kind of write up about that's like psychologically everything. Yeah. All of the women who do this have had their own children and have done well. I think as a general rule, probably, yeah. I have not heard that specifically, but it would make sense because you're trying to minimize risk for whatever you can minimize. And so you don't want someone who has either mental illness component or medication, right? Yeah.
It's above and beyond the standard care.
Yeah, it is. And it's also, it's a big financial thing. I mean, like there's a lot to it.
Yeah. Okay. And then my next question was, do you work with because I know that you work with prenatal and then while they're pregnant and then after. So do you work with women to help them bond with their child if they're struggling to connect?
Absolutely. Yeah. It's one of the more, I love doing that. Yes. A lot of women struggle to connect with babies. And this is not related to having any PMAD. We have this image in our society that you're going to deliver, you're going to see your baby and you're going to be like, I love you. You're the greatest thing in the world. And sometimes that happens. And sometimes it doesn't happen. And that's okay. I always tell women it will happen. You will fall in love with your baby. It will happen today, maybe not. Maybe it won't happen tomorrow. Maybe it won't happen this month, but it's going to happen. And we just work together to figure out the best ways to do so. But yes, I do. And it's really great and rewarding and fun.
Okay. I forgot my last question.
That's all right. Thanks for coming on, Hannah.
Yeah.
Thank you.
Jordan.
Hello, can you hear me?
Yes, we can.
All right. So my question revolves around a male perspective of this specialty. I know when it comes to OBGYNs and different specialties that revolve around women's reproductive, a lot of women can have uncertainties when it comes to a male physician. And I was just kind of curious from your perspective or your male colleagues' perspective, if you've discussed it with them, some of the uncertainties or some of the obstacles that they may come across venturing into this field, as well as currently practicing within this field.
Awesome question. I will tell you that one of the biggest people in my field, one of the guys who I respect most and who has the greatest say in my field, is a man. And he's awesome. His name is Lee Cohen. He's at Mass General. Love him. He's brilliant. Women flock to him because he's brilliant. I'm sure I've heard him. He's the first to say he has not been through the experience of having a child, right? He has children. Right. And that does change things, but that would change something if for a woman who doesn't have kids. And, one of my mentees, so to speak, she's an amazing reproductive psychiatrist and she doesn't have kids yet. She will, I'm sure, but she doesn't. I do think for me, the way I practice, the fact that I have kids does help me because I can use my experience from, this is what happened when my kid did X, Y, and Z. Because in my kind of psychiatry, frankly, that whole Freudian crap about, being a completely blank slate, that goes out the window for me. Maybe it's just my style, but I don't think that it's fair to, not say anything in this scenario. Like if I understand what they're talking about, because I went through it, like I can tell them that it'll get better from personal experience. So that for me helps, but I don't think it's mandatory. And there are so many amazing reproductive psychiatrists who are men and who, separately are women who don't have kids.
Yeah. That was my main question. Thank you so much. And thank you, Dr. Gray. We all appreciate you.
Yeah, no problem, Jordan. Thanks for coming on. All right, Dr. Snyder, thank you so much for your time again. Again, for everyone here watching this, the podcast, Specialty Story Session 94, we go into a lot more different discussion around the specialty of reproductive and perinatal psychiatry. So thank you for spending your evening with us.
Thank you. This was so much fun.
Yeah, everyone have a great night. And Dr. Snyder, thank you so much.
Thank you.
Bye.